Good afternoon, everyone, and welcome to today's webinar with Families USA, COVID-19 State Opportunities in the Next Federal Response Package. We're so grateful to have everyone joining us today. And for those of you who joined our last webinar on state strategies and COVID response, welcome back. For those of you who are joining today, welcome to you as well. I'm Lisa Hunter, the Senior Director for Strategic Partnerships at Families USA, and we're really enthusiastic to see such a strong showing of interest in today's webinar. Our very high-level goals for this webinar are to, first and foremost, equip state partners, each of you, with information and updates on COVID response legislation and policy, and highlight the ties from the federal policymaking that's happening down to state implementation and advocacy. And then second, and this is perhaps more important, is to make sure that we're inviting your questions, your comments, your observations on experiences that each of you is having during this really challenging time. We know this is a unique moment in our history as a society, but also within the health movement and the work that each of you is already doing. We at Families are really committed to working with partners to ensure that each of you is able to do the critical work that you do and serve patients and vulnerable communities and all of America's families, just to make sure that everyone has access to coverage, services, and are protected from financial harm and discrimination at this time and beyond. So thank you for everything that you all are doing. And frankly, you all are seeing the response effort at the front lines, and so we're really sincere about wanting to hear from you the challenges and needs that you are facing, what's working, and what we need to push for. So similarly, given the federal activity on COVID, there is an important opportunity to lend your voices to the policy priorities that we're going to be discussing during the webinar today. And if you haven't already seen it, Families USA is circulating a large sign-on letter to Congress, and we'll need everyone's help to signal strong showing of support for these priorities, including with your congressional delegation. So please, if you haven't already, take a look at the link and sign the letter by close of business on Monday, April 21st. And any questions, please feel free to reach out and let me know. So, as you'll see here on our agenda, very shortly I'm going to be turning things over to Frederick Asasi, Families USA's Executive Director, who is also currently very steeped in the federal relations activity happening around COVID. So he'll provide an overview of what's going on in Congress and help explain what's likely to come. Then we'll have Elliot Fishman, our Policy Director, who will dive into the major priorities that Families USA is pushing along with national and state partners on the upcoming quote-unquote COVID-4 package, and relating those policies back to what states and state partners should watch for and help elevate and feed into. And then I want to allow for sufficient time for questions and answers, as well as an opportunity for folks to offer some of their thoughts and comments. And we'll have policy staff on the line who can help answer those questions, and then we'll wrap up. But first, a quick word on housekeeping. Today's webinar is recorded, and we will be sending out a link with the recording and slides to all who RSVP'd and joined. For the Q&A portion, because of the size of today's webinar, we're going to be using the chat box function. So throughout today's webinar, we're going to invite each of you to submit your questions, comments, and thoughts into the chat box, and we'll be monitoring those questions and teeing them up for the Q&A portion. So with that, I'm going to turn it over to our fearless leader, Frederick Asasi.
Hi, Lisa. Can everybody hear me clearly? Let me know if you cannot. Thanks so much. It's a joy to be here with all of you. And we very much hope you, your loved ones, your families, and your communities are staying safe in this very difficult time. Congressional activity, I'm here to just give you guys a really clear view as to what's going on the Hill. It's been a very, very frenetic and chaotic time on the Hill the last couple of months in relation to COVID. And I would say this is even more intense than the 2008 Recovery Act that you guys might remember from about 12 years ago. It's really pretty extraordinary. What's most important to say about this is that it is critical that all of you stay involved. The process is moving with lightning speed. It's a very, very imperfect legislative process. You know, there's no time for the normal committee work, Hill briefings, etc. And so it's moving so quickly that you can't go through the normal deliberative process. But on the other hand, there are also these are some of the largest bills ever written in the history of the country, massive amounts, $2 trillion. So they present really extraordinary opportunities to make a very, very big difference very quickly. And our philosophy has been to jump in, work with the Hill, focus them on the most important priorities that allow families and the nation to stay healthy and safe and have access to testing and treatment and financial security. And we're really proud of the work we've done. I think collectively, with all of your support, we've been able to make a real difference in the bills that have moved so far. We're also very, very focused on equity issues and the terrible reports that we're hearing about how the virus is impacting communities of color, and in particular African Americans, and it's starting to impact rural communities. And so we've been doing a lot of work in that dimension as well. So let's start by just reviewing what's happened. And let me go ahead and advance the slide. Okay, so the first bill that passed was the Coronavirus Preparedness and Response Supplemental Appropriations Act. That was back on March 6th. It feels like probably 6 years ago, but that was March 6th. And that was the very initial effort by Congress to start to address coronavirus before I think anybody really understood how big the impact was going to be. That was the emergency funding by $8.3 billion for federal agencies, and then the $20 billion for small business loans, and then some healthcare provisions, for example, improving telehealth services in Medicare. Then a couple weeks later, the Families First Coronavirus Act passed. That was so-called COVID-2. And that included the unemployment benefits, paid sick leave, insurance coverage for COVID-19 testing, not treatment but testing, funding for nutrition assistance, and the very important 6.2% FMAP bump needed to provide states with funding, state fiscal relief funding, to protect both their Medicaid programs and all of those state programs that are so vital to a lot of low-income families. You know, everything from nutrition assistance programs to elderly programs, kids programs. Then we moved on about a week and a half later. That was on March 27th, we passed the Coronavirus Aid, Relief, and Economic Security Act. That was so-called COVID-3. That was the really, really large bill. It was $2 trillion in economic stimulus. It included $150 billion to support healthcare providers and hospitals, about $340 billion for state and local governments, again, to support both their immediate response to COVID, but also this double whammy of as people lose their jobs and become uninsured, they go onto a lot of state programs, so there's increased demand, and then the revenue for states goes down as their income and sales tax collections go down. So really important to protect those vulnerable families and the programs they use, that state fiscal relief. We had a very big role in that. We're very proud of that. We also got $4.3 billion for the CDC pandemic response, and a boost to unemployment insurance, the direct cash payments, the small business grants and loan forgiveness, the so-called Paycheck Protection Program. And then we moved on to what some folks refer to as COVID 3.5, where this was the effort on the part of the Senate to move additional funding, just strictly funding for the small business provisions, including the Paycheck Protection Act, which I believe yesterday ran out of money. That has not moved forward successfully. There's a real debate going on between Republicans and Democrats about the scope of that bill. And then that leads us to what we're working on now, which is called CARES 2.0, or a lot of folks are referring to it as COVID 4.0, so the next COVID Act. We're working very, very hard on this, working with key members to get priorities in. There's three key criteria that we've developed with the congressional staff we're working with for inclusion in the 4.0 package. The first is that the policy is directly linked to helping the nation respond to the COVID crisis. So it has to be a very strong COVID link. The second is the policy has a very clear need for congressional action. And then the third is that the policy will bring immediate relief to families struggling with COVID. In other words, the relief won't start months and months after the legislation is enacted. And these criteria are very important because they give staff and members the ability to fight really hard to include them in the package. So current predictions are that this package is going to start in the House and then move over to the Senate. We were very successful in getting a lot of priorities in a COVID-3 package that Speaker Pelosi introduced, which is, many have the sense, is kind of the foundation for the COVID-4 package. So we're in good shape. We've got some good priorities in there, and we're working behind the scenes to provide a lot of technical assistance to the key staff drafting provisions. Pelosi has announced that members will be coming back around May 4th at the earliest. So that gives us a couple weeks to get the priorities in the bill. Now, at the same time, there's this effort to get COVID 3.5 done, and so we don't know, will it at some point pick back up and move quickly, or will it merge into COVID-4? As the COVID-4 package takes more time, it's possible that instead of the House going first, the Senate will just go ahead and move. So there's always a possibility the Senate will move quickly and try to act before the House. But right now we're still thinking it's going to start in the House. So we have a good 2 weeks, and then hopefully the foundational package comes out from the House. It's sent over to the Senate. And then our next opportunity to push really hard to get priorities in legislation will be when the Senate's working on their version, and that's likely, kind of early to mid-May. And so that's going to be another really big push point for us. And then we're not sure exactly when COVID-4 will wrap up. The tendency on the Hill is for Congress to take really big legislative pushes and line them up with recesses. And the next big recess we know of is likely to start around May 22nd. That's the Memorial Day recess. So that's a lot of folks are guessing that's probably going to be the end date for the COVID-4 package work, trying to kind of line everything up so that when Congress goes out on recess around the 22nd of May, that work is wrapped up. That's the current guess. So again, an incredibly intense period of time, a great deal of opportunity. Our most important task is to identify the key legislative targets for staff and members and push them to be bold and secure very big wins for the health of families, and particularly the most vulnerable around the nation. So I think that wraps up my overview for congressional activity, Lisa.
Great. This is Elliot Fishman. Thank you, Frederick. And I am, as Lisa mentioned at the start, the Senior Director of Health Policy here at Families USA. And I'm going to be following up on Frederick's presentation to talk through what the specific policy proposals are that we are asking for your energetic support on, and specifically why these are so urgently needed and such potential difference makers at the state level. I think for many of you, we have you at hello because you are very much living both as advocates and as citizens and people who are living through this terrible time, the kinds of issues that we're talking about. But hopefully it's useful to just talk through the specific priorities that are in the sign-on and why federal action is needed and why in particular state governments need federal action here. So as you can see, we have 5 broad priorities described here. I'll be talking about some of the sub-priorities that fall under these headings. And the first is to ensure access to affordable health insurance coverage. As you know, tens of millions of people are losing employer-sponsored insurance in a extraordinarily catastrophic loss of insurance coverage, certainly unprecedented for our country. And of course, they are losing health insurance not in an economic crisis alone, but in a healthcare crisis. So really a nightmare scenario where people are losing health coverage at exactly the time when access to both medical care and to financial protection from catastrophic medical costs could not be more important. So what we are putting forward as priorities at the federal level involves multiple channels of trying to reach both people who are uninsured before and people who are newly uninsured to ensure their access to care. And that involves first significant enhancements to premium tax credits for people both at the low end of the subsidy range for the marketplace and people at higher incomes, So comprehensive approach to enhancing premium tax credits within the marketplace involves, and this was a piece, as are a number of these pieces that were part of the Speaker Pelosi package for the third COVID bill that Frederick was talking about a few minutes ago. 100% subsidization of COBRA costs for people who have COBRA coverage, who are eligible after having newly lost ESI. As many of you know, because of the out-of-pocket costs, many people who are eligible for COBRA don't take advantage of it, the vast majority. And this would at least remove the cost obstacle to taking up a COBRA option. A third element is to take the very narrow new state option to cover COVID screening and testing costs for uninsured people that was in the second COVID package, and to expand that to cover COVID treatment at 100% federal match, which is obviously very much needed for people who are merely getting screened and tested and who screen as positive. It's not clear where they go from there if they remain uninsured for treatment of what they have just been screened as positive for. And also to extend that uninsured category so that it covers people who are uninsured regardless of their immigration status. And as of now, that uninsured 100% FMAP state option is limited not only to lawful permanent residents, but a subset of lawful permanent residents that will be familiar to people who deal with Medicaid eligibility and immigration status to qualified lawful permanent residents. It's a narrow slice of immigrants and unfortunately a very inadequate state option when you think about who is uninsured. The fourth priority that we have here, and one that was not part of the earlier COVID package and really needs to be part of how Democrats, and ultimately hopefully on a bipartisan basis, we as a country are approaching the crisis of uninsurance that we are up against now, is to have a surge of enrollment assistance funding and staffing. As you all know, we've seen great reductions in federal funding for navigators and enrollment assisters. And when people are losing jobs, especially in the midst of an otherwise extraordinarily disrupted time, when all sorts of living arrangements and income and housing arrangements are all being disrupted at the same time that people are losing jobs, it is very difficult to expect people to navigate themselves the process of signing up for benefits broadly, and health insurance is not necessarily their first priority, even in terms of signing up for benefits. At a time when there are massive backlogs for unemployment insurance, among other benefits. So in the absence of a great deal of enrollment assistance, we have learned from previous recessions that it is very hard to reach newly unemployed people with broad messaging around how to sign up for care. It's really a time-intensive process to get this population covered. And the final element of what we are proposing and asking for your aggressive support for around coverage is to have a marketplace option in addition to the Medicaid option that I described above, to have 100% FMAP for COVID treatment, to also have a marketplace option in which marketplace can cover COVID treatment costs down to 0% of the poverty level. We have in mind especially states that potentially would not take up even 100% matched option around a broader uninsured category, that the marketplace could step in and reimburse those costs, so that from a provider perspective, there was either Medicaid or marketplace reimbursement for COVID treatment costs. That is with regard to the first bullet that you are looking at on this slide, ensuring access to affordable health insurance coverage for all. The second bullet is one that is easier to go through what we are proposing, and certainly, again, something that I think many people on this call are living and are about to live as we go through states revisiting their fiscal year budgets. We are headed into a massive state budget crisis. I think it's increasingly clear that it's going to be even worse than 2009. And our proposal involves building on the federal Medicaid match increase that was in the second COVID package, to build on that, significantly recognizing the depths of the fiscal crisis that states are about to be in, to also make available additional COVID relief funds, and to postpone the reduction in CHIP program, Children's Health Insurance Program, match rates that's currently underway. All of those are intended to be not just fiscal relief for states, but also involve significant shoring up of healthcare funding at a time when healthcare funding could not be more critical. As we talked about on our previous webinar, and I think many of you have seen our resources and our sister organizations' resources around the maintenance of effort provision, all of these funds through enhanced federal match are tied to states not making cuts to Medicaid. We'd like to see that broadened to CHIP, so there would be a maintenance of effort for CHIP 2 that also involves not disenrolling, as does the Medicaid MOE, not disenrolling anybody from their health insurance in the middle of this pandemic. Those funds and the protections that are associated with them are just incredibly important across all of the populations who are most vulnerable in this pandemic. When we think about the health equity concerns that Frederick spoke about a few minutes ago, think about the concerns in skilled nursing facilities where Medicaid is the dominant payer, the need for additional support for home and community-based services, where Medicaid is again the most significant payer. Providing states with additional Medicaid dollars is both an economic crisis measure and a public health crisis measure. The third area we have here, so I'm on the third bullet on this slide, is safety for the workforce. And anybody who reads a newspaper can unfortunately see how state efforts, while vital, are inadequate without a stronger federal role here. And we worked closely with labor organizations on these priorities. The first is to have national distribution and a structured national allocation of protective equipment, both for healthcare workers and more broadly for essential workers at this time. Also to maximize the use of the Defense Production Act to ensure an adequate supply of personal protective equipment. And our final element here is to end the exemptions to paid leave, to the paid leave provisions that were in the second COVID package. As you know, we are a global outlier when it comes to lack of legal paid leave protections. it shouldn't have taken a pandemic to move us to where every other advanced country is, and we are still not there, even with the pandemic provisions that were in the second COVID package. The fourth area, our fourth bullet, is to organize our national public health capacity. And important context for this is that there is a growing consensus on the need to eventually move, once we have sufficient COVID testing capacity, to a test, track, and quarantine approach to protecting public safety while reducing social distancing. It would be terribly dangerous and dangerous in a way that particularly endangers the same people who are most vulnerable to COVID, which is people with chronic illness, people with disabilities, older people, low-income people. All of those people in our communities are have their lives at stake around decisions to potentially move away from the mitigation steps that we've taken to this point without sufficient public health capacity. However, we are not going to get to sufficient public health capacity at the state level alone. We need significant new federal funding to enable states with federal leadership to staff up their community public health staff, and we need substantial new federal staff to work with states in order to implement both the specific test, track, and quarantine approach, and more broadly, to restore the cuts to basic public health infrastructure that took place by attrition over time, year after year, over far too long during a time of unfortunate complacence with regard to the risk that we were taking with lack of public health funding. Part of what we are proposing is also to definitively put the CDC in charge and to make sure that public health professionals are in the middle of how we are allocating these resources. The fifth area, affordability and access to care, and the final bullet on this slide, covers telemedicine. It's particularly important, and I think it's important for those of you who are active in state capitals around Medicaid advocacy, for telehealth services to become an alternative to traditional face-to-face medical services for obvious reasons. And it is especially important, again, in a Medicaid context, that telephonic telehealth services, that is not just video services, become available. We are proposing a federal mandate around that. Many Medicaid beneficiaries don't have access to video-based telehealth services, and many Medicaid providers may not have access on their ends. A second area is around surprise billing. Some of you may have seen that the Trump administration put out an executive order tied to the COVID emergency stabilization funding for hospitals, barring surprise billing. That's a welcome step, but we really need to have strong statutory protections around surprise billing that are more comprehensive and not only tied to COVID services. There are a lot of people who are using out-of-network providers because their provider relationships have been disrupted by mitigation or by the broader social disruption that is happening under this pandemic. And many of us are at risk for surprise billing more than ever and need robust statutory surprise billing protections that are long overdue. there's also a continued need for more robust statutory protections against price gouging, and specifically around profiteering in prescription drugs. Of course, we are all rooting for the pharmaceutical industry right now, but at the same time, we as a country have left ourselves in an extraordinarily weak position, particularly in the United States, to prevent the pharmaceutical industry from taking advantage of the leverage that they will have as COVID treatments are developed. What we are proposing is to waive any pharmaceutical exclusivities with regard to drugs that they manufacture. We don't want to be in a situation that those of you who remember when HIV drugs were developed, there was a period of years before they were made broadly available. And to require reasonable prices in a reasonable and fair level of profit for pharmaceutical manufacturers rather than an extortionate level of profit. So that is a tops of the wave summary of our federal agenda, very much centering on what we see as the core federal responsibilities here. I do want to note that there is a parallel state agenda that both aligns with these concerns and focuses on some key state roles. That's something that we spoke about in a webinar 2 weeks ago. And we anticipate a publication that should be coming out before the end of April that updates specifically on some innovative ways that states have either taken action or have federal waiver proposals in which they are trying to take action both to stabilize their healthcare systems and to extend coverage and make that coverage as seamless as possible for people who are losing employer coverage. So keep an eye out for a state-focused publication soon, but in the meantime, we desperately need your help to get a federal legislative agenda that can support both states and really all of us as we get through this public health emergency. And with that, I am going to hand the mic back to Lisa.
Excellent. Okay. Thank you so much, Elliot. That was great. And thank you guys so much as well. I know you guys have been sending in questions, so we're going to move on over to that portion of the discussion, which gives us ample time this time around. I think for some of you who were with us last time, I know we ran a little over, and so this time we wanted to make sure that we had questions and answers and budgeted appropriate time. But for awareness, we did post on April 3rd, following that first webinar on COVID and state strategies, a list of FAQs that came out of that discussion. And you can go to our website, familiesusa.org, and look at the resources tab, and you'll be able to find that FAQ document. And should we need to do a similar document or update the existing FAQs following this discussion, we are more than happy to explore that. And so we thought that we wanted to leave, again, as much time as possible to each of you to ask questions and share learnings, thoughts, and comments. We're interested in understanding what your observations are, what's working, what is working well, what are the most critical resources you need in your communities now, and with the constituencies that you're serving and you're working with. But I'm going to go ahead and dive into some of the questions that we've gotten thus far. So feel free to keep populating those questions in the comment box as we go along here. And we have one question asking for clarification of policies around SOPs, which I think is SEPs, special enrollment periods, and the differences between federal and state policies. Stan Dorn from our policy team, if you're on, are you able to speak to that?
Sure, absolutely. Thanks so much, Lisa, and thanks to all of you for being on the call with us this afternoon, and this morning, depending on where you are geographically. So special enrollment periods, as you know, are times when people can sign up for exchange coverage or other coverage in the individual market outside the annual open enrollment period. Almost every state that runs its own exchange has created a COVID emergency special enrollment period that lets anybody sign up for coverage right now. And in Maryland, for example, 20,000 people have signed up for coverage through the special enrollment period. And what this does is not just get people into exchange coverage, you get them into Medicaid. In fact, more than half of the new enrollees in Maryland, just as an example, have been Medicaid folks. The spur to enrollment is the special enrollment period. People can wind up getting either exchange coverage or Medicaid coverage. The federal exchange has decided that they are not going to create a special enrollment period for COVID, and this was a decision that came out of the White House.
Stan,
yes?
Stan, can you hear me? I just want to let you know you're coming in a little muffled.
Oh, I'm sorry. Okay, thanks. So at the federal level, there's no special enrollment period specific to COVID. They made a clear decision they're not going to do that. But there are pre-existing special enrollment periods that some consumers can qualify for. So if you lose your job and you lose access to minimum essential coverage, you have a special enrollment period. If your income goes down so that you didn't qualify for premium tax credits in the past and didn't sign up for coverage, but now you do qualify for premium tax credits, you're supposed to be able to enroll. There are other circumstances as well, pregnancy, having a baby, moving, but these are limited. And so the opportunities to sign up for coverage through special enrollment periods can be much broader in state exchanges than in the federal exchange.
Great. Okay. I'm looking at some of the questions that have come in. Here's a coverage question, actually, for folks on the policy team. Well, it looks like it just came in. Can the uninsured be charged for tests at provider offices or health centers? I don't know if Stan or Cheryl or Elliot are on the line and want to speak to that. This is, can the uninsured be charged for tests at provider offices or health centers?
This is Cheryl, and I'll start and would appreciate it if my other policy colleagues chime in if I say this wrong. There are a couple mechanisms in the legislation that would allow uninsured to get free testing. One is if there are grant funds that are available that allow providers to provide free testing both outside and inside of hospitals. So that would be one way that people could get free testing. Another mechanism for free testing is through Medicaid programs that provide waivers to cover uninsured people for testing. So if you go through either of those mechanisms, there should be free testing available in provider offices, including FQHCs. That doesn't mean that every uninsured person who goes to any provider will get free testing, because it would need to be a provider who was getting reimbursed through one of those mechanisms. Am I saying that right? Does anybody have anything to add from the policy team?
Yeah, this is Joe. The one thing I'll say on the Medicaid front is it's a state option to cover the uninsured for the testing. And as Elliot mentioned, there's 100% FNAP for it, but states have to elect to do that either through a disaster SPA or a disaster 1115 waiver. And we're starting to see states have gain approvals for that fairly quickly, and I think that will continue to happen fairly quickly, but it is a state option, so the state will have to take action.
Okay, great. So this is about testing, but it's also getting into funding and federal funding to cover COVID testing for undocumented persons. So I believe we have Amber Hewitt on the line. She is the Director of Health Equity for Families USA, if you haven't met her already. I'm going to let Amber take this one. And Amber, we've got actually quite a few questions here related to equity around not just undocumented populations, but also just generally how these priorities can then address disparities. I think this can give you some opportunity to talk about the stakeholders and partners that you've been engaged with, especially at the national level.
Sure. Thanks, Lisa. This is Amber. I'll speak to the first part of the question around ensuring healthcare inclusion for immigrant communities. And there's definitely a call for Congress to leverage Medicaid to not only cover COVID-19 testing prevention, but also treatment, including a vaccine when it's available. And that's something we're hearing strongly from health equity advocates focusing at the intersection of immigration and healthcare. In addition, what we're hearing from health equity advocates, which I'm sure we've seen the news around the stark disparities in COVID-19 health outcomes and the need for comprehensive data collection, and not just the collection of the data, but reporting and analysis related to race, ethnicity, and primary language. The last time I checked, 25 states along with DC have released disaggregated data by race and ethnicity, but the need for making sure that we're calling for data collection on primary language. And this is really important because if we see disparities, say, in a vaccine uptake or hospitalizations, this really gives us an early warning sign and allows us to sort of get ahead of the issues. So it's not just about having the data, but how the data can sort of target funding and target resources. A couple other things that we're hearing before I turn it back over to Lisa is the need for resources for language access. And the big need here is around funding, because we all know that the healthcare system is, the capacity is strained. So there is a need for sort of leveraging Medicaid and CHIP and providing resources to the CDC for the translation of public health materials. And the last big thing, I think Elliot mentioned one of the concerns from the disability community around funding for home and community-based services, which is very, very important and vital. And I'll just add one other thing there is around prohibiting rationing of COVID-19 treatment and critical care resources and not using disability or age for categorical exclusion for the use of those critical care resources, such as ventilators or critical care beds. Lisa, I'll turn it back over to you unless I can fill in anything based on the questions that you're receiving.
I think that's great. All right, I'm just going to keep going through the list here. So we got a couple of questions around the exchanges or the marketplaces and their ability to support newly uninsured folks who lost coverage to their employer who have been, tragically been laid off. Stan, I'm gonna lob this one to you around support for folks who are rolling off of employer-based coverage and what states can do to supplement that federal premium assistance. What, if anything, can be done on COBRA? It looks like somebody asked about, can we get COBRA extended for 90 days. Are you able to speak to this?
Yeah, absolutely. So let's start with the latter, COBRA 90 days. I assume the question is, it could be about one of two things, the COBRA election period or the period of time to enroll when you've lost your job and you've lost your employer-based plan. You have 60 days for the special enrollment period that applies in every state in the country. So let's take them sequentially. In terms of the COBRA enrollment period, there's legislation that was recently introduced from out of the House Education and Labor Committee that would provide various changes to COBRA to make it a more realistic option to laid off workers. It would notably pay 100% of the COBRA premium, and it would also pay 100% of workers' share of employer-based coverage for furloughed employees, people who lose more than a certain percentage of income. They get fewer hours. They're still offered group coverage, but they can no longer afford to pay their share. 100% premium subsidies are very significant. And for those, instead of means testing at the front end, it's all paid up front to people who want that subsidy. And then when you file your federal income tax return, if your income's over $250,000 a year for married people filing jointly. Yeah?
Hey, Stan, I'm sorry. You're still a little tiny muffled.
Okay. I'll speak slower and louder. At the end of the year, when you file your federal income tax return, if your income is high, you may need to pay back some of that COBRA subsidy, but coverage is affordable to you on the front end. The bill does not extend the 60-day COBRA COBRA election period generally, but it does say that if you were laid off at any point since March 1st and you did not elect COBRA, you can elect once the bill passes. And it also says if you elected COBRA and you paid premiums, you can get compensation for that. So that's the COBRA piece. In terms of the special enrollment period for people who've lost their jobs and lost employer-based coverage, generally speaking, there's certain periods of time for special enrollment periods, but nothing would prevent a state from building on that and saying you get extra time. In terms of what states can do, Elliot talked about the importance of application assistance, how most efforts in the past to help laid off workers have just failed to reach the target population, except for the few efforts that provided very intensive application assistance. So one possible approach that we've been talking about with a couple of states is to build into the unemployment insurance application process an opportunity for the worker to ask to have their contact information and social security number shared with the state health agency to help the worker get free or low-cost health insurance. And so sharing that information, starting that process that would need to be followed up with intensive application assistance, that's something that states could potentially use the federal dollars, the $150 billion federal stimulus package that states can use for any purpose, or disaster relief fund. So those are a couple of things that states can do that we think are very promising.
Great. Okay. Joe, I think this one is for you. The question is, can someone discuss the importance of general financial support to states and localities beyond FMAP per se to protecting against healthcare cuts at state levels because of cratering state budget revenues?
Yeah, absolutely. Thanks for the question. The FMAP provision is hugely important, and we've been pushing for it and pushing for more. But there are limitations, right? The FMAP is drawn when there are expenditures and healthcare expenditures. And if there are lower in volumes because elective procedures aren't happening, dental care is certain volumes going down, behavioral health services volumes might be going down for all sorts of shelter-at-home reasons, there are going to be some big limitations in dollars that are flowing down. For that reason, we've been asking at the federal level for additional state fiscal relief, not necessarily tied to the expenditures the way the FMAP will be drawn down. In addition to that, there are some creative ways that states can use existing authorities and hopefully even more funds come down from the feds that will help to try to ensure provider support, which is such an important access consideration for both short-term and long-term. If providers are going out of business, you're not going to have access to some of those critical services. So we're starting to see some opportunities around retainer payments to long-term care providers. The state Medicaid agencies already have that option through 1115 waivers. There's an opportunity that the National Association of Medicaid Directors is pushing to expand that to other essential Medicaid providers. There's also opportunities through MTOs to get additional pass-through or directed payments to providers to try to keep them whole as compared to the previous year payments, as well as some other supplemental payment opportunities. Some of those don't necessarily completely speak to some of the budget shortfalls. I think a lot will really have to help. A lot of that help has to come from the federal government and state fiscal relief. But in the interim, there are ways that states can do a little bit more on that front. The other thing that I'll speak to just briefly is the uninsured, because that 100% FMAP option for states does hopefully help quite a bit here. And there are a few states that have taken action to try to expand that through waivers, again, in absence of federal legislative pathways. And I want to just point to California very briefly. California has made a decision that they're going to include treatment, and they would love to get that Medicaid financing for it, but they've already moved forward and told their providers and the beneficiaries in the state that they plan on covering treatment. And so the state has moved forward with guidance around presumptive eligibility for this category. And they are hoping to get CMS to say yes to 100% FMAP for that population. So I think there's a lot of ways that states can get a fairly creative, again, in the absence of federal action, but that federal action really is going to be the thing that provides opportunities for state fiscal relief.
Great. And actually, before I know you have to jump off in a couple minutes, Joe. Really quickly, we just got another follow-up question. When does FMAP emergency period end in Families First Act, or what is the duration or expiration of the emergency period?
It's tied to the emergency period. Okay. So that is when it would end, and I think there are definitely worries about a cliff happening at the end, whether that's the FMAP, whether that's the meaningful effort, whether that's the uninsured category. These temporary benefits just one day expiring, maybe in a hypothetical situation where the president declares the national emergency over before we really think that it's over. So I think that's another place that if there were a, rather than an FMAP tied to the national emergency, but an FMAP tied to economic conditions or other conditions that gave a little bit more of a ramp, will be a really important protection that legislatively could help quite a bit.
Okay, great. Another question, do you think, and I think this one's for Stan or even Cheryl, do you think the coverage gap will be released for those in Medicaid non-expansion states who cannot receive subsidies for the health exchange plans? So put differently, do we think subsidies will now be given to those who are 0 to 138% FPL in non-expansion states?
So under current law, the subsidies in the exchange do not go to those folks, people in the coverage gap. The bill that passed recently that created a Medicaid option for testing, for COVID testing, would let a non-expansion state pick up that option and get 100% federal match to test people in the coverage gap, but it would not provide them with services. The new legislation that we anticipate that there would be the COVID-4 package, we're advocating that it include an ability for states to expand that option, that 100% FMAP supported option, to include Medicaid treatment for COVID, not just testing. And in that case, that would be potentially available to adults in the coverage gap. But of course, there's no guarantee that the states that have been stubbornly resistant to expansion in general will take up this new option to help poor COVID-diagnosed adults. So with that in mind, we're proposing in our sign-on letter that if there's someone with COVID who's in the coverage gap and they don't have access to Medicaid, that the federal government should step in and provide them with premium subsidies and full coverage of out-of-pocket costs, so that, you know, in the states that just continue to ignore the needs of their lowest income residents for whatever reason, that at least the folks with COVID would get affordable coverage and care.
Okay, great. Actually, Stan, I have a feeling you might be able to take this one too, or others on the team. Feel free to jump in. Would the UI transfer of information to the enrollment assistance only work in a state with a state exchange? So this is talking about some of the what you discussed earlier a few minutes ago. Or would FFM, Federal Facilitated Marketplace, accept these referrals?
I can't speak to what the FFM would do, but in an FFM state, I would have the data portal, the data transfer go to the Medicaid agency, if that's a sympathetic agency, and have them be the ones who start the enrollment process. And in general, it depends on the state, but in a lot of states, laid-off workers are better off going to, if it's an expansion state, often better off going to Medicaid, where the first question is, what's your income this month, as opposed to what do you think your income is going to be over the course of the entire year, including the income you earned while you were previously employed. So if you're an FFM state and your state Medicaid agency is a reasonable place, then that's where I would send the information and start the outreach and enrollment assistance. And the other advantage of that is you at least get federal administrative match to cover some of the costs of the application assistance, and then hopefully you can bring some of the new federal funds in to cover the rest.
Okay, great. All right, this is the last question, although this does not need to be the end of the conversation, so please feel free to reach out to our staff if you have questions following. And I noticed that we are circulating the link to the sign-on letter that we've been discussing today and the priorities therein. I think I'm going to give this one to Elliot, and it is around health and wellness impact of isolation on impoverished persons with disabilities is even more severe. The digital divide is now Grand Canyon-esque. Suggestions on how to attempt to bridge that divide. Funds to attempt to provide technology support both now and in the future as connecting virtually in the months ahead.
So I'm going to answer this question, which is both extremely important from a public health perspective and heartbreaking from a human perspective, from a couple of different directions. I think we at Families USA certainly would be very supportive of technology funding that was targeted at increasing access to broadband for impoverished people with disabilities. I'd also say that just from my perspective, it's not our area of expertise, and we would always need to be deferential to people who work specifically on technology policy in that area. But there are a couple of different elements of the sign-on letter that we've been talking about today that I think very importantly speak to the problem that you're describing. The first is increasing our public health capacity to move past, as soon as we safely can, social distancing and mitigation approaches to a South Korea-style approach of broad testing, tracking, and quarantining. That's important, first of all, to enable more of the social contact that is particularly missing for people with mobility limitations or who are otherwise really deprived of human contact right now. And I'd also say, just from a safety perspective, because people with disabilities are particularly vulnerable to the virus, that we ought to be gravely concerned about a premature move away from social distancing that could create another surge in virus cases, particularly for the help of people with disabilities. So without the ability to really dramatically increase our public health capacity, it's both the concern that we can never safely move past the isolating strategy that we're using now to try and flatten the curve, and the concern that pressure is going to build to unsafely move past that strategy in a way that is physically endangering to people with disabilities. So that creates a double urgency around that public health spending. The other element that I wanted to note is specifically around providing support for home and community-based services. So that involves elements of providing direct funding to those providers at a time when the regular revenues may not be available, and also extending personal protective equipment, which we talked about, so that we can maximize the safety of home and community-based services care providers as well as the consumers who they work with. Those are both elements that I think are needed, but as I mentioned at the start of my response, we would be very supportive of appropriate federal technology steps to more directly deal with the Grand Canyon-esque digital divide that you described in your question.
Thank you so much, Elliot. And thank you again to all the state partners that dialed in. You have our contact information here on the slide. Feel free to reach out to any of us with any questions. Again, the deadline for the sign-on letter is Monday, COB, on April 21st. And just to reiterate how important it is to have state representation behind the priorities listed there, and to be in touch with us about how we can help elevate the priorities that you are carrying as well. As you are engaging with other advocates in the states, we respectfully ask and would deeply appreciate if you would share the letter with others in your networks and sister organizations, and also raise this for the awareness of your congressional delegation and also your governor, because that's another way that we're hoping to get these asks made to the Hill coming from governor's offices, is another just sort of powerful way for folks to echo some of the priorities here. And with that, thank you very, very much, and don't hesitate to be in touch. Thank you again. Stay safe.